Our next speaker is Andre Davila, who is going to talk to us about the biophysics of ablation in scar tissue. Andre is from the Hospital Cardiologico in Santa Catarina, Brazil.
Thank you, Dave. So, for us to discuss the biophysics of RF in scar, let me review a few concepts in a different way. Because we have to realize that current density, which will eventually be the reason for you to ablate, mainly depends on the amount of current, but also of the impedance through which current is trying to flow. If you have zero impedance, there will be no density there. Current will not concentrate in a given area. And that's what we do, right? We have a small electrode, and because of this, we can create heat in this side of the bipole. If you have an area with a very large indifferent electrode, you can have current there, but there will be no heat there. And we all know that current is very critical for this. But I'd just like to call your attention for one specific thing. It's extremely important to understand that the way the current will flow away from the region, it totally depends on the impedance of that specific reason. I'm telling you this because there will be an implication of this comment during the presentation. So when we look at the scar in terms of VT, we all know that impedance is different from healthy tissue to scar. You can see it here. As we go from areas of normal tissue here to scar, the impedance will change significantly. And we can measure that with our ablation catheter in a very rudimental way, because we are basically measuring the impedance between your catheter tip to the indifferent electrode. But even doing so, we can measure differences in areas with normal, areas with fat, which do not change the impedance, at least based on the method that we use to measure it during ablation. But when we place our catheter in scar, the impedance will be always lower. This is important because for the sake of this presentation, let's assume that impedance has a correlation with electrical conductivity. So as you can see here, if I have an area with high impedance, it means that I have a very low electrical conductivity. And this is important because the main reason, the only difference between scar and normal tissue is the impedance. If you look at all the other variables here, they're not different. You have basically the electrical conductivity and the presence of flow, blood within the vessels. If we take these variables into account and we plot this in a computer model, we will see what's been shown for decades, that scar is great for radiofrequency ablation. So the concept that scar actually prevents us from ablating has no explanation using this kind of computer models. As you can see here, when we mimic that, when we try to understand the temperature profile between scar and normal tissue, as you can see, if you take these variables and plot them here, a scar will always favor RF conduction, RF heat. This has been shown a long time ago by Dr. Kottkamp. He published this very interesting paper, and what they did was to place some thermocouples inside the scar, and as expected, as predicted by computer models, what you see here is that when you compare what's happening between normal tissue and a scar, you can see that the temperature profile, it's basically the same. And as you can appreciate it here, when you burn in these areas with chronic infarcted myocardium, you can heat 50, 55 down to 6 millimeters, which would be more than enough to destroy that area. There is also this other interesting paper showing what they did. They were basically working with a needle electrode and measuring temperature around this electrode. And as you can see here, it's a very busy slide, but to summarize it, The temperature profile and the size of the lesions were exactly the same when they were comparing normal tissue, patchy scar, or dense scar. So it was possible for them to conclude that scar does not affect lesion size or doesn't create any changes in terms of the temperature profile inside the scar. So when we take this to the clinical arena, there is some data suggesting that this is the case. This is an old paper from Dr. Stevenson, and they actually took this patient to the lab twice for a refractory VT, and the patient had a problem after the second procedure, but anyways, they were able to dissect and show that within the scar, the lesion can go as deep as 3.5 millimeters, which in some ways should be sufficient for you to kill that region there. So everything looks fine, because if I have then this kind of substrate, which is ideal substrate for you to ablate, so you just have to place the catheter in this isthmus area here, and because in this particular area you're going to have a high impedance, higher than what you will see in a scar, ablation here will be an excellent way to ablate, because current will concentrate in this region, and this is what you're going to probably see. This is what you're going to see. You have nice electrogram, you have a favorable substrate, and as you ablate, VT will stop immediately. The problem is that when we see what we do in our patients, it doesn't work like that most of the time. So when you try to eliminate the late potentials, or when you take different criteria to assume that you had a good ablation there, what you typically see is a very disappointing result. So although we know we can do that, but in general, what we see, it's a very difficult or minimal changes as we ablate. So there is experimental data showing that RF and SCAR, that SCAR is good for RF. But when we look at the clinical data, our results do not point in that direction. So how can we reconcile these two big differences there? So let me use the model reported by Jacques de Backer. Let's look at the scar, the interaction between scar, shown here in blue, and live tissue. Instead of looking at this from the electrical point of view in terms of signals, let me look at this, taking into account the electrical conductivity, in other words, the impedance. In areas of scar, I'm going to have higher impedance, which means very low. In areas of scar, I'm going to have a low impedance, so conductivity will be very good. And this is totally different from what you see in the so-called isthmus there. So if this is correct, let me ask you a couple of questions. If the conductivity is different depending on the component of the scar that you're nearby, can current flow preferentially to areas with low impedance, to areas with very high electrical conductivity? And if it does that, so how temperature is going to behave inside the scar? Let me show you what we typically see, and let me see if I can explain that. So this is a potential substrate with areas with a very low electrical conductivity. So when I ablate, my current will possibly flow to areas with very high electrical conductivity, in other words, to areas with very low impedance. This can possibly explain this kind of case. This is a patient that I did a few years ago, and as you can see here, I have interruption without capture. And you would anticipate that you are right there. In sinus, you have late potentials, you have a very interesting point here. And I would expect this VT to stop immediately as soon as I push the pedal. But as you can see, it took like 15 seconds for this VT to stop. So this kind of phenomena could be explained by current flow going away from what I'm recording, because my catheter tip would be surrounded by areas with completely different impedance, favoring electrical flow to different directions. So if I take the example again and I look at my scar now in terms of electrical conductivity, and I plot this with my 3D model, I can actually suggest and explain why we don't see like very good results when we try to ablate VT. We can suggest that perhaps because of the differences that you see in terms of electrical conductivity and impedance inside the scar, current can actually have preferential directions to go, which would explain why we cannot ablate many of these patients despite of the fact that we have a very interesting, a very good electrogram in our hands. That's not the only reason for you not to be able to ablate. Let me just show you briefly a quick study that we did with Arash Ariana in Sacramento, trying to understand the role and trying to understand how flow and the presence of intrapericardial fluid will affect ablation. Very quickly, just for you to see that when I ablate epicardially, if I use 35 watts, it doesn't matter the kind of flow that I use during my ablation. The size of the lesion will be exactly the same for a given catheter at the same power. But look at this. Depending on the catheter that I'm going to use, the lesion size is totally different. So it's not simply delivering 1 watt with one catheter or another. In this study, when we're using a new catheter, the lesion size was actually significantly larger than the ones that we typically use. So the catheter design can affect lesion size as well, which has to be in some way with the way that current will flow away from that catheter tip and interact with the scar. When I try to analyze if the scar, if the ablation is different when I have absence or presence of fluid inside the pericardial space, as you can see here, if there is no fluid in the pericardial space, lesions are going to be very similar regardless of the infusion rate. If you're using 5 or 15 millimeters per minute, lesion size will be very similar with a contact force of 10 grams. However, if you, on purpose, if you inject 100, 150 cc's of saline inside the pericardial space, as you can see here again, depending on the flow, my lesions will be, again, quite similar. So the flow does not change lesion size, but the presence of pericardial fluid does. As you can see here, when I compare for the same infusion rate, lesions created with and without fluid inside the pericardial space, the lesion dimension is totally different. If I have fluid in the pericardial space, which will potentially drain current away from the myocardium, in some way, the saline has a very high electrical conductivity, lower impedance, so current will go on the opposite direction, similar to what I'm trying to say and propose for ablation with scar. And as you can see here, when I have fluid in the pericardial space, my lesions are significantly smaller than when I burn with a dry pericardial space. So just to conclude my presentation, I think the impedance scar, as we all know, it's lower than in normal tissue, which may cause current to drain away from your target. And that can explain why despite of all the change that we've seen in terms of mapping, our clinical results in terms of VT recurrence is not changing as fast as the mapping systems are changing, because we have a limitation in terms of the energy source that we use for most of these patients. So in other words, I think that RF lesion size depends on scar architecture, depending on how you have to ablate, on where your catheter is positioning in terms of areas with low and high impedance, you may not be able to ablate that specific area. And just to complicate everything, catheter design, and in terms when it comes to epicardial ablation, catheter design and the presence of epicardial flow can actually impact lesion formation out there. Thank you for your attention.